Hi, everyone. Thank you for joining this breakout session on Family MUAC. Just going to give it a few minutes here for people to find their way to the breakout room, and then we'll get started. For those of you just joining us, welcome to this Family MUAC breakout session. My name's Amanda Yourchuck. I'm an emergency nutrition advisor with USAID Advancing Nutrition. I'll be your facilitator for this session. Before I introduce our two speakers, we have just a few housekeeping items. For those of you that were with us yesterday, the breakout session should be set up in a similar way to yesterday's plenaries. But for those of you who are just joining us, if you're having any technical difficulties during the session, you'll see a chat box over to the right-hand side of your screen. Just put a note there, and we have some technical support people who can help you access the session. If you have questions throughout the session for our presenters, there's also a Q&A tab. Please put your questions in that Q&A box, and we will try to get to as many of those as we can at the end of the session. So with that, I'm going to go ahead and get us started. So our first presenter today is Diane Moyer. Diane is a nutrition advisor with Concern Worldwide, covering the nutrition portfolio in Concern's Francophone countries. She has more than 10 years of field experience in Asia and West and Central Africa in both humanitarian and development contexts. Our second presenter is Dr. Heather Stobaugh. Dr. Stobaugh has 10 years of experience engaging in a variety of research studies and technical advising for development and emergency nutrition programs around the world. She now continues her research at Action Against Hunger US and teaches at the graduate level at Tufts University. So with that, Diane, I'll hand it over to you.
Hello, everyone. So today we are going to discuss about Family MUAC. Yesterday, Family MUAC was mentioned as one of the easiest intervention to scale up access to malnutrition. It's something that's easy to do, that's cost effective. So we are going to discuss about how to do it in any type of context. And my colleague Heather will discuss about how to do it in COVID context. So where we are with Family MUAC. Family MUAC, it's not a new approach. Actually, it has been implemented in countries for more than 10 years. What is aimed to, for the people that do not know, it's to support mother and other caregiver to identify early signs of malnutrition in their children using a simple to use MUAC test, meaning that we want to shift the task of screening children from the health staff to the mother, empowering the mother in knowing how to detect malnutrition in their own children, but also in the community's children. So why we want to do it? Because late referral has been identified as one of the main causes of complication, medical complication, hospitalization, defaulters. So we want to be able to detect earlier these children. We want to make sure that the mother has the power to manage the children's health and to relieve the community health worker from this task, meaning that the community health worker will be able to carry out other tasks like IYCF sensitization or any type of morbidity treatment, etc. So as it was quoted in ALIMA guideline training of trainers, ALIMA being the pioneer in terms of setting up Family MUAC, putting mother at the center of malnutrition screening strategy, acknowledge that they are in the best position to detect the early sign of malnutrition. So that's really the key information to keep in mind, that the mother has the power, they have the capacity to do it, and building their capacity on how to do it will really help them to take this decision and refer the children. So what has been achieved? So as I said before, 10 years ago, ALIMA piloted the approach in 2011. And in 2018, we estimate that up to 1.3 million mothers were trained in 26 countries by 12 organizations. of course, since then, a lot more mothers were trained in many more countries, especially with COVID, and the adoption of Family MUAC by NGO, but also by government. So here you have a map of where the Family MUAC is being done. So it's clearly, as you can see, it's not something limited to 1 or 2 countries, but it has clearly been adopted by most of the countries in sub-Saharan Africa. And you can find it also in some countries of Middle East. So in terms of impact, so I think there is enough evidence to show that this approach is working. So what we have seen, quality of detection, ability of mothers to correctly detect and diagnose malnutrition and edema. This has been proven that mothers can do as well as any community health worker. The timing of detection, that by empowering mothers to do Family MUAC, to do this detection, they know they could screen the children. They could screen the children earlier. The quality of treatment. So by screening children earlier, we have an impact on quality of treatment because the children arrive with higher MUAC, so the time of recovering is shorter. There's less risk of developing complication, and because the time of recovery is faster, there's less risk, there's fewer risk of defaulting. Of course, impact on coverage and sustainability, because the mother, it's not something that's costly. Once you have trained the mother and you are encouraging them, it's something that could last for a long time. And because you are using this mother as another mean to screen the children, we can improve coverage. So when to scale up the Family MUAC approach? It's a question that always comes up, like saying, okay, I want to do Family MUAC, but should I do it? How should I do it? So you should consider doing Family MUAC in the following case. You have a high burden of malnutrition combined with a low CMAM coverage, saying like, for example, you have like 10 to 15% of GAM, but you realize that your coverage for CMAM is very low because the geographical coverage is very low, because there's low access or low screening. There's a late admission of some children, so meaning that the mother show up to the health facility too late. And there's an implementation of a no-touch policy. Heather's gonna discuss more about it, but just for you to know, Family MUAC was actually piloted during the Ebola crisis in Western Central Africa and has been considered as a good approach when you need to follow up on the nutrition status of children, but you are not able to have a physical contact with them. And of course, as it will be discussed in other group and through the week, it's great to support the pilot or scale-up of simplified approach. Like, for example, when we talk about MUAC only or ICCM malnutrition, you want to combine it with Family MUAC to make sure that the children are early refer and detect and refer approaches. So now you have assessed your context and you want to do it, but you want to be cautious of what has been working well and what might limit your implementation. What you need to do first? First, you need to develop an SBCC strategy. Family MUAC is not about technical skill. It's not about being able to use the MUAC. It's also being able to want to use the MUAC and to want to continue to use the MUAC. For example, when we were doing follow-up assessment of the Family MUAC approach, we noticed that after a few months, mothers either do not use the MUAC anymore, or they don't know how to use it, or they don't want, even if they are using it, they still don't want to refer the children because they don't understand what's the priority, why we should refer children. So that's why it's very important to develop this SBCC strategy. You want to make sure that there's MUAC and trainers. So depending on what will be your target, if it's like, for example, mother of children under 5-year-old or mother of some children, depending on the context, you want to make sure that you have enough MUAC to cover all the mother of the children. And you want to make sure you have enough trainers to train this mother, because one-shot training is not going to work. You want to follow up on this mother to make sure that they are not only they are able to do it, but they want to do it and they continue doing it. You want, and this is a key element, to identify and integrate existing community mechanisms, what we call entry point, or community, so it could be done either at the health facility, like for example, point of contact between trainer, which can be a health staff and a mother. So, for example, the CMAM, management of childhood illness, growth monitoring, but also could be ANC and PNC, like if you want to work with pregnant women. You want also to consider community-based intervention, like, for example, support group or part of the community health worker basic package or blanket distribution. Meaning you don't want to add a new layer of intervention. You don't want to add more work for the community health worker or for whoever is going to support this approach. You want to use what's already existing. Any point of contact, preferably repeated point of contact between a mother and trainers. You want to build on existing monitoring and evaluation systems. So it's true that sometimes we are bound by our donor to report on different type of indicator, but you want to avoid adding too many indicators that will not be able to be sustainable, meaning that your the local partners, the Ministry of Health, will not be able to measure them on the long term. So the recommendation would be to set up maybe an exhaustive list of monitoring of many indicator at first when you want to make sure your approach is working, but on the long term you want to use what's already in the system. Now, looking at the barrier. So what barrier has been raised by partner in the past year when implementing Family MUAC? So even though it has been adopted in the national protocols, notably I think in Mali, in Niger, in several countries of Western Central Africa, there's still low integration. It's still an NGO-led approach, so it's something we need to work on. We have been observed also some logistical delay to supply MUAC, particularly if you are targeting a large number of mothers, like for example, if you are thinking of reaching all the mothers of reproductive age, or if you are all the mothers of children under 5, so you might not be able to get enough MUAC in time. So there's also the question links to coverage, like not equipping mother and training on how to detect their children. It's not enough to address the barrier linked to access. Like if the health facility is too far, the mother will not self-refer or will not accept any referral. So there might be an issue with also with acceptance if you don't work on a proper SBCC strategy. We have also observed that without regular support, regular monitoring, regular training, there's a capacity and frequency of screening that is diminished over time. So you need to follow up. That's why when you design your approach, you need to make sure that you will have enough staff, enough manpower to monitor this woman. And the weak monitoring, because again, we don't make sure that the human resource are enough. We are not able to monitor, particularly if you are going for a large target. So, if I want to resume, thinking back about your country, you're already doing CMAM, you are already doing Family MUAC, but you want to scale up. Or you know how you want to scale up right from the beginning. What do you have to keep in mind? There's no one magical bullet. There's no one size fits all approach. I cannot tell you have to go this way and you will work. What's work in Malawi might not work in Kenya, might work in Kenya but not in Niger. So what you want to make sure that you need to understand the context. You need to understand what will be the most effective and sustainable. When you look at the training strategy, like how you're going to empower and follow this woman, you have to consider existing model and lesson learned in the country and existing entry point for the training. What I said before, you want to look at how your system is working. What are the points of contact between the mother and the health staff? Can it be the support group, like the core group at the community level? Can it be like OTP attendance? It can be anything, but you want to consider the different entry points and you want to use what's already existing. Again, think about your resource, think about your context, think about your objective. If you have limited resource, you may not want to go for a larger target. You may want maybe to focus on the most vulnerable. So again, it will depend on what you have and what you want. Key messaging. As we said before, SBCC is a key element of a Family MUAC strategy. So you need to make sure that you have a key messaging ready for the content of the training. Meaning, like, when you will do the training, it's not only about explaining a mother how to take a MUAC, but explaining her why she has to do it, why she wants to do it, what's the importance of early referral, what's the cause and consequences of malnutrition, etc. You want to make sure that she wants to do it. So you want to make sure that the message we give with the training is adapted. Monitoring and evaluation. Of course, I don't implement without monitoring. So you want to focus on outcome, like, for example, how many mothers you have trained, but also on impact. One useful indicator to measure impact is the proportion of some children referred by Family MUAC, meaning, like, for example, if usually you are doing house-to-house screening or this massive screening every quarter, and most of your SAM children coming from this screening, you want, once you have implemented Family MUAC approach, you want to see a higher number of referrals coming from Family MUAC, meaning there's fewer children depending from the NGO phone screening. So meaning we ever have a higher coverage, or screening will become more cost effective. You want also to look at coverage of mother. Like, for example, if you go for a large coverage, like saying all mother of children under 5, should be trained and receive MUAC, you want to measure how many women actually receive it. And so you can do it, like, for example, using LQS methodology. You want, like, for example, to measure, okay, how many mothers were trained, how many still have the MUAC, how many are using it, how many have screened their children in the past week. So it's type of sub-indicator you can use. So I think that's the main element I wanted to share. So once again, Family MUAC is a great approach. It's relatively cheap. It doesn't harm. It's only help to build awareness amongst mothers. So you want to do it because you want not only to improve the coverage, but you also want to work on the perception of malnutrition, adhesion to treatment, and early referral. And I would like to thank you. You will be able to find more information on the website acutemalnutrition.org. And without transition, I will let Heather tell you more about how to do Family MUAC and why to do it in COVID context. Thank you very much.
Great. Thank you so much, Diane. Let me see if I can share my screen and get my presentation going. All right. Wonderful. So as Amanda mentioned earlier, my name is Heather Stobaugh, and I am from Action Against Hunger US. And I'll be speaking a little bit more about Family MUAC, specifically as it was implemented during COVID-19 pandemic. When the COVID-19 pandemic began, many implementing organizations started putting in place adaptations in their programs that were designed to manage child wasting. And the aim of these adaptations were to continue the life-saving services while at the same time reducing the risk of the transmission of the virus. Following guidance by UNICEF, the Global Nutrition Cluster, and WHO in March and in September of 2020, many organizations adapted their CMAM programming using adaptations that had been previously piloted or implemented in research studies that had known benefits of protecting against the transmission of the virus, or I would say potential protection of transmission of virus. So Action Against Hunger, with support from USAID and in collaboration with UNICEF and the CDC, decided to capitalize on the opportunity to document lessons learned of all of these adaptations being put in place. So we conducted a mixed methods study. The study The study's aim was to systematically document, analyze, and synthesize information related to these adaptations being put in place around the management of child wasting. And we did so using multiple methods. First, we implemented a survey and distributed that as widely as possible to ministries of health and implementing partners, and received 242 responses across 42 countries that documented who was implementing what types of CMAM adaptations in the context of COVID-19 and where they were being implemented. We then followed up with a proportion of those respondents to conduct qualitative semi-structured interviews to try and capture the on-the-ground operational implications of implementing such adaptations. And then thirdly, we tried to collect as many M&E indicators for the programmatic outcomes where adaptations were implemented. We received about 21 data sets, and we're in the process of analyzing that quantitative data to see if we can see any trends in programmatic outcomes where adaptations were implemented. So some of the results of that initial survey that we implemented showed that Family MUAC was the most frequent adaptation that was implemented. And we noted that it was implemented across 35 different countries. Now, this is not to say it was a nationwide policy in 35 countries or it was even scaled largely across 35 countries. This is just to say that we received data that Family MUAC was implemented at some fashion in 35 different countries. You can see here the different adaptations that were less frequently implemented than Family MUAC. So why was Family MUAC probably the number one most adopted adaptation? In the context of COVID-19, as we're all probably aware, most of the mass screenings and surveillance systems were either canceled or suspended due to COVID. And in theory, Family MUAC would have the potential to lower contact between clinic staff, CHWs, and children. And implementing Family MUAC had a relatively lower risk than some of the other adaptations that were suggested to be implemented during COVID-19. Family MUAC didn't necessarily require a significant policy change to implement it, and it required relatively low level of technical training and low level of resources and inputs to put in place compared to some of the other adaptations that were implemented. So what were some of the operational implications that we were able to document from the qualitative interviews that we implemented? First and foremost, the acceptance of Family MUAC was mostly very positive and quite high across the board. For caregivers and community members, it was highly accepted, and there was a very consistent report that there's a sense of empowerment for caregivers and community members who participated in the Family MUAC program. For community health workers themselves, we had some mixed results in terms of acceptance. Most of the time, community health workers welcomed the Family MUAC approach and saw that it lightened their very busy workloads, such that they saw themselves partnering with caregivers and transferring some of the responsibility of screening and trying to identify malnourished children to the community themselves. But on the other hand, we did have cases where community health workers were not enthusiastic about it, as they did not want to relinquish what they saw as their professional and trained responsibilities onto untrained community members themselves. So with community health workers, as Diane mentioned earlier, it may not be a one-size-fits-all approach, and there would need to be a high level of sensitization around both community members and community health workers to understand different roles and responsibilities. For direct clinic health staff, again, Family MUAC was very highly accepted, and in several occasions, it was noted that there was even improved relationships between the clinic health staff and the community themselves, because caregivers and community members now had a much better understanding of the program admission and discharge criteria for the management of wasting. One note around supply and logistics is that there was an overwhelming preference for color-coded MUAC tapes. Most of the populations that were being served where acute malnutrition are at high rates have very low literacy levels, and therefore it was well noted that the color-coded MUAC tapes were really the best way to go in order to train caregivers and other community members how to implement Family MUAC. In terms of training, there was a wide variety of training models that were implemented, but by far the most model that was implemented during COVID-19 was sort of a cascading training model, where a curriculum may have been developed by an implementing agency or a Ministry of Health, and then you follow sort of a training of trainers that would cascade down to community health workers that would, at the lowest level, train a small group of caregivers. And the number of caregivers was often dictated by whatever policies were in place around the number of people that were able to gather during COVID-19. And again, one strong point that came across in many of the interviews was the need for low literacy training tools and job aids that were specific to their context. A few respondents noted that being able to leave a pamphlet or to leave some visual aids with the caregiver in addition to the MUAC might help with increased uptake of Family MUAC among the caregivers. We did see some results around staffing implications to implementing Family MUAC. Many organizations were anticipating a potential increase in staffing needs due to increased admissions from caregiver self-referrals. And also, staffing increased needs were anticipated due to the refresher trainings and follow-up trainings that would likely be needed. As you heard in Diane's presentation before mine, that it's most likely to be effective if there's more than just a one-time training of caregivers, that over time refresher trainings would likely help the uptake and effectiveness of Family MUAC. So what were some of the challenges that we were able to document from a research project? Very consistently across all of the interviews that we conducted, procuring a sufficient amount of MUAC tapes for scaling to the desired scale that the implementing organizations wanted to do was the #1 challenge. So where did this leave them when they couldn't, where they were not able to procure a sufficient amount of MUAC tapes? They were left to then prioritize sort of high-risk groups. For example, many of them distributed MUAC tapes to caregivers who had children that were being discharged from a CMAM program, with the intent that they were at high risk of relapse and that the mothers could continue to monitor their nutritional status going forward and catch them if they relapsed quite early and bring them back. We did note that many respondents in our interviews reported that the accuracy of caregiver referrals was, it varied greatly across the interviews and different contexts. Some estimated that about 70% were accurate, and some estimated that as low as below 30% were accurate. Now, these were anecdotal reports. We were not able to look at any documentation or M&E because it was quite early on in the process of piloting and implementing Family MUAC. However, we did see a wide range of actual accuracy of caregiver referrals. We also noted that many respondents said that it was difficult to really ascertain and understand what was going to make their Family MUAC services sustainable. So as Diane mentioned earlier, and we noted that refresher trainings have been recommended at the time of COVID-19, and when many organizations were piloting this for the first time, there wasn't such a strong, clear plan to understand how to make sure those services were going to be sustained. And in some cases where Family MUAC was used in the place of a surveillance system, there were some challenges in making the new data that was color-coded or categorical sort of line up with the previous data that was numeric. So there was basically less specific data now coming in, and policies that didn't really, or next steps or action points that didn't really align with the new data coming in that was categorical. So there was a need to sort of adjust decision-making trees and the like around surveillance systems. We did have several respondents say that there could be some frustration among caregivers who came as a self-referral, but were not admitted and did not receive any services. The two instances we noted this happened was when MAM services were not available. So the Family MUAC program trained caregivers to measure their children's MUAC, and if their child's are measured in the yellow color, that they should report to a clinic and receive services that their child was malnourished. However, in many cases, the treatment of MAM is not available, and so caregivers would turn up at a clinic and unfortunately be turned away. Another instance was when a MUAC measurement was not accurate. Many, as you noted in my previous slide, many referrals were not accurate, or if they were very close, right on the border of being malnourished, and caregivers were turned away because they didn't meet the strict criteria. So there was some frustration there when caregivers tried to utilize the Family MUAC model, but unfortunately were turned away from services. And generally speaking, there was reported a lack of program guidance. So not so much around design, standard M&E indicators, that it was difficult to monitor. And because it's a new approach, there isn't a lot of evidence-based practices yet documented or established. Diane did a great job of outlining sort of the history and where we've come with Family MUAC, and we do know a lot, but it is still a newer approach. And not a lot of evidence-based practices have been yet established. So just to wrap up, in terms of next steps, there was very much a call for further program design guidance. As you heard Diane mention, one size does not fit all, and there was a call for more guidance around designing Family MUAC programs, and a need to identify exactly how to improve the accuracy of referrals. A call to develop uniform M&E indicators so we can develop more best practices around Family MUAC and knowing what is effective. And same around understanding how to make Family MUAC, the design of Family MUAC, lead to sustainability of its services. And overall, just a wanting of identifying best practices to ensure improved CMAM treatment outcomes. So again, as Diane mentioned, you can see more information at acutemalnutrition.org, and I will stop there for now. Thank you very much.
Thanks, Heather and Diane, for those presentations, and thanks to all the participants who have been putting questions into the Q&A. So we have about 15 minutes or so where we can go through as many of these as possible. So I'm going to start out with some questions related to the messaging that needs to go along with Family MUAC, because I think this is a really important issue for programming, and it sounds like it has a lot of implications in terms of how community members view the approach and if they keep it up. So I'm going to merge a few questions here, but there was one question asking what should be the messaging if a mother is taking the MUAC and they see it's coming up green, but she still feels maybe that the child is malnourished, or perhaps there's something else that's wrong. What kind of messaging would you advise so that she would still maybe seek care at the health facility, even if perhaps the issue wasn't that the child is wasted. And related to that, if the mother is going to the facility and not actually receiving services because the measurement was inaccurate, what sort of messaging or approaches might you recommend to mitigate that? Could the health workers perhaps show her the measurement, give her some quick refresher training? So I'll put it to you, Diane, first to give some examples from your field experience, and then Heather, if you want to follow up with anything that maybe came out in your qualitative findings.
Thank you, Amanda, for this question. Actually, it was something that was brought up several times during workshop and listen learned on Family MUAC. What is important is before you start anything to have a good understanding of how your system is working. What type of service is available? Do you have SAM treatment? Do you have MAM treatment? Do you have a sound community health system? What are the role of the community health worker and how you're going to work with it? Because one of the issues we've highlighted is sometimes the community health worker might be a bit reluctant to this approach because they see it as a competition to what they are already doing. So they feel like the mother are kind of stealing their job. So it's very important to work with the community health worker to make sure that it's not like replacing them, but working with them and to empower them and saying, you are the one helping the mother, you will be the one referring. And that's why also I want to add, one thing you can do to avoid this false referral is to set up a cross-check system, meaning like if a mother finds a child or own child or the child of a community being malnourished, she will go to a local community health worker to get the child cross-checked, meaning it will be the community health worker that will refer the child. So let's say a child is MAM and there's no MAM treatment. So if the community health worker has been well trained, he or she can provide some IOCF counseling, for example, and maybe tell the mother, okay, so your child is at risk, but is not severely malnourished yet, so we are not going to refer him, but please adopt these appropriate practices, breastfeed your child, wash your hand, etc. And maybe he or she wants to tell the mother that she should monitor a child frequently to make sure that the child doesn't fall into malnutrition, into severe malnutrition, and if it happened, to refer as early as possible. If the child and the mother manage to go to the health facility and being denied admission, we want to work with the health staff to make sure that the mother is kind of actually of being reward for doing the effort of measuring the child, of bringing the child to the health facility, and of keeping the child healthy. So we don't want the health facility, the health staff to say, okay, you are bothering me, I don't have time for this, go back home. So it's something we need to work on, which not be always easy because, as you know, health facility staff are very busy. So it's something that is come with welcoming condition that we need to work on. I don't know if I answer all the question, Amanda. I mean, I'm sure there are some addition.
Yeah, thanks, Diane. Heather, do you have anything you want to add?
Not too much. I think Diane said a lot of really great comments, but just to maybe reiterate that we never want to discourage health-seeking behaviors. So in the messaging, to make sure to nuance that if you ever think your child might be ill or in need of health services, to seek them. Knowing that if you measure your child and the MUAC is green, they may not likely be admitted to the nutrition program, but if there's a mother that thinks her child is ill in any sense, to always seek healthcare services. It may be another illness that needs to be attended to. So just to add that on to Diane's comments, but none more for me.
Great, thanks. So here's a question that's related more specifically to the COVID context. Actually, I'll ask you two at the same time here, and you can both respond at the same time. So since Family MUAC was flagged as one of these promising approaches for use during COVID, have either of you noticed an increase in interest in the approach in terms of actually integrating this into the health system or a rapid scale up? And again, on the flip side of that, if you have been seeing a rapid expansion of the program, has there been challenges? I know MUAC, there's been a lot of demand for MUAC tapes also at the health facility where we're trying to, sanitize them in between patients, and therefore we need more of them. So how do you sort of manage that at the same time while you're trying to encourage the scale up of this approach? So Heather, I'll let you start this time and then Diane follow up.
Sure. So indeed, we did see, as I mentioned in my presentation, Family MUAC implemented in a lot of new places, or where it may have been piloted prior to COVID-19. There was a desire to scale it up even further to try and continue the identification or detection of malnourished kids in the community, where many of the mass screenings and surveillance systems were suspended. Again, the challenge of trying to meet the demand with MUAC tapes, I think, had a little bit of a limitation on the degree of scale that was able to be implemented. So it's very much a balance. And as I mentioned in my presentation, I think the organizations in the Ministry of Health recognized that and were able to try and target where and how they were implementing Family MUAC to try and make sure to reach the most at-risk groups with the limited supply. But I do know that in terms of governments and global leadership across the UN, there's very much a sense of wanting to explore Family MUAC more. There's not as much a reluctancy to adopt it as some of the other adaptations. And therefore, there's work being done to seek solutions to try and meet that demand with MUAC tapes. Diane?
Thank you, Eva. I think you covered most of it. My experience from Sahel is that Family MUAC was already well in place when COVID happened, so the switch, the scale up was kind of done naturally. What we try to make sure that we adapt the training setup to COVID recommendation. Like, for example, if entry point was support group, we make sure that support group is limited to 10%, respecting physical distance, wearing a mask, etc. What we try to do is, like, let's say your entry point was a community health worker doing door by door, so saying, okay, how do you have to ask the mother to come outside, wash your hand, wash your child, wash the MUAC, etc. I remember there was a lot of discussion on how to clean the MUAC, like how to keep it, and there was also discussion on making sure that each child coming to the health facility has his own MUAC and how to clean it again. So again, as Heather said, it was an approach that was easy to implement. The only cost was getting the MUAC, so something it was a bit challenging. There was a lot of delay, but the implementation was kind of easy as long as you were using a good entry point and respecting COVID recommendation.
Great. So here's another question. So it seems like there's been, a lot of traction being gained with Family MUAC for children under 5. Is there any interest, or have you seen any movement in using this for pregnant and lactating women, for example? I know that probably comes with other challenges. They obviously can't measure themselves, and the adult MUAC tapes are a little bit harder to come by. But have you heard anything about that emerging as a possible approach? I'll open that up to either of you.
I have a quick answer.
Go on, Eva.
Okay, just my quick answer. In the context of COVID-19 with our research project, we did focus on children under 5 for our research study, but there were discussions about how to implement that with pregnant and lactating women, but it certainly was not scaled or implemented to the degree of identifying malnourished children.
As of for me, I saw it back when I was working with Save the Children in Burkina, where our entry point was mother-to-mother support group. So as we were giving counsel to the mother on how to screen their children, we also trained them on how to do it on themselves. So again, as Eva says, the difficulty was to get some adult MUAC, even to some child MUAC was working on the mother. I mean, at least it was something they should be sensitized about and how to do it. But again, you want to be cautious on how to generate demand if there's no offer behind. Like saying, okay, you are malnourished, but there's nothing I can do for you, can be a bit a frustration for mothers. So it's about monitoring their own well-being, but also about offering some appropriate care, even if the care is limited to counseling.
Great. So I'm seeing a few questions here related to the training side of this approach. So one question is, how often do you recommend providing sort of that refresher training to the mothers, or maybe checking in on how accurate they're doing the measurements to help mitigate that issue of perhaps going to the facility when the measurement's inaccurate? Diane, I know you mentioned having it cross-checked, but from the training side, are you giving them refreshers? And also, what strategies have you used to help cascade this down to reach as many mothers and community members as you can, often probably considering limited resources in many contexts? So I'll let you start, Diane.
Okay, so I think most of my answer will say it depends, because it depends on the country, it depends on your resources. So how many staff do you have to monitor the mothers? So what I would say is, when you will pick your entry point, you want to choose an entry point where mother will come often. So like, for example, growth monitoring, mother come every month to monitor the child. OTP, you know, they will come every week for at least 8 to 10 sessions, etc. The best, I think, is, that's my own appreciation, it's a mother-to-mother support group, because you know the mother will be in for at least several weeks or a few months, so, and coming every 2 weeks. So you want to use this entry point to deliver the initial training and to do refresher, like, meaning each time the mother come, you take the time to, let's take a concrete example, support group, you will do an initial training, and then next meeting, okay, how many mothers have screened the child? How is it doing? Doing the screening, discussing about how the mothers are doing it at home. Because when you are doing it, like, for example, to support group, it also gives you opportunity to discuss with the mother about the challenge you might be facing. So I will say, choose an entry point that allow you to have the longest contact and the most regular contact with the mother. So something where the mother will come back very often and on a long period. And then it will be great to have a follow-up, maybe for 6 months and 1 year after. It's quite interesting, and I think both ACF in Senegal and French Red Cross in Mauritania did this type of survey where they measure 6 months and 1 year later how many children still got, how many mothers still they got the MUAC, how many were still measuring, etc. So this is when it comes to training. But again, it will depend on your setup and on your resources. You don't want to add on the workload of community health worker or on the health staff. You want to make sure that whatever you ask them could be integrated within their existing workload. And Amanda, the second question was about how to do most with nothing.
Sure. Yeah. I guess you maybe sort of answered that. And again, it probably depends. But in terms of cascading the approach, the training, what are some of the strategies you've used? Do you have community health workers roll that out? Is it often government or supporting partner staff?
I think it's kind of hard to have a very strict answer on it, because you can say, okay, I want to have a large coverage with limited follow-up, hoping that maybe 50% of my, 100,000 mothers will still get their MUAC in 6 months' time. Or maybe I want to go for a smaller target, like maybe 20,000 mothers, but I know that because I will follow up on this mother, these 20,000 in 6 months, in 1 year, they will still use the Family MUAC. So I think that I like to use systems that are, how can I say, like, for example, if you look at support group or care group, where the participants are training over members of the community, is something that could be sustainable, because it's something that once your main trainers are being trained, they can train on their turn, etc. So you have to build on what's already existing in terms of knowledge building and knowledge sharing, like what existing system in terms of support group on communication can you use to maintain this training. Because the success of Family MUAC is not only about knowing how to use the MUAC, it's really about wanting to use it and doing it frequently. And these are really behavior components. So you need to have an SBCC approach to do it. I don't know, Heather, if you want to add any further points.
Great. Not too much, Diane. Thank you. I would say that we saw, at least with our research in the context of COVID-19, just a wide variety because of the restricted movements and the restricted group gatherings that were allowed in so many different contexts. And a lot of times, those platforms that Diane's talking about that you would normally build upon were not there. They were canceled. Care groups weren't happening. ICCM wasn't necessarily happening, or just that movement of community health workers amidst communities weren't happening. So we did see a good amount, where possible, of digital trainings using mobile phones and tablets to sort of do that cascading of train the trainers down to as close to the community as possible. To try and get those messages out there and then distribute the MUAC tapes as well. But in the context of COVID-19, especially in the early months where the movement was quite restricted, it was challenging, but there were a lot of innovations that took place. And even a lot of cool things, respondents mentioning that they would use dolls to do demonstrations, and in addition, where maybe digital methods where videos couldn't be played or responded, and different tools like that to maintain social distancing and limit physical contact during those trainings. So a lot of innovations were implemented during the context of COVID-19 because there were just those additional constraints in the context.
Great. Well, thanks again, Diane and Heather, for sharing all of your insight and experience with this approach. I think we're going to wrap up. Thank you to all the participants that came to this breakout session. We tried to get to most of your questions, but there is a discussion room. So if you look to the left-hand side of your screen, you'll see a tab for discussion rooms, and there is one focused on Family MUAC. So please feel free to go there, share your thoughts, post extra questions. The content from that discussion room will be reported out on Thursday when we talk about some of the key topics and takeaways for scalability at the end of the conference. So there'll be a short break now for about 10 minutes, and the next round of breakout sessions will start at 1:15 GMT. So you'll again find the options to choose your next breakout section to the left-hand side of your screen under the Agenda and Information tab. So thanks again for joining us, and have a great rest of your day. And please do visit that discussion room, and we'll keep the conversation going. Thank you, everyone.
Thank you.